Good morning, everybody. Hi, my name's Nancy Pike, and I'm a professor at UCLA in the School of Nursing. You met myself and Dr. Love, as she mentioned, at your recent retreat. And today I'm going to talk to you a little bit. This isn't my area of research, but it is the population that I serve, and it's an important population for you to be familiar with, just because of their increased risk for early caries, as well as their increased risk with sedation for dental procedures. So I'm going to be talking to you about congenital heart disease today and infectious endocarditis and what you as providers need to know. And I'm not sure how much content you received on this in your previous coursework. So this may be a little bit of a review, but I thought I would give you some examples of the various things that you will be providing antibiotic coverage for. So when you see these names or you look at the guidelines and you're not sure what a shunt or a residual defect is or a particular valve, these things will become a little bit more clear to you. So I have no financial disclosures, but I am on the American Heart Association as a liaison to the American Academy of Pediatrics, and I'm on the Congenital Heart Public Health Consortium Committee. Let's talk about a few definitions before we get started. Congenital heart disease means it is inborn or existing at birth. It's a defect or abnormality that occurs during the development of the heart or blood vessels near the heart before birth. And then we have acquired heart disease, which is typically what we get with aging, or it may occur later on in life from an infection, such as rheumatic fever, or Kawasaki's disease, or from endocarditis. So those are some of the potential conditions. Most commonly, we see acquired heart disease associated with atherosclerosis in adults. A little bit on the statistics that are out there through the CDC and the American Heart Association. It affects approximately 40,000 births per year. It is the #1 congenital defect in the United States, and that is in comparison to the other type of congenital defects, such as cleft lip palate, club foot, hypospadias, and spina bifida. 15% of congenital heart disease is associated with a genetic condition or syndrome. And 30 to 50% of congenital heart disease have physical, developmental, or cognitive deficits that kind of progress along and follow them across the lifespan. And these are important things to know, especially when you're seeing and treating a child that has congenital heart disease, that they may be delayed or behind in their speech, their motor, their developmental milestones. 50% of congenital heart disease will receive some sort of an assistance in school, such as an individualized education plan or IEP. Many types of defects occur alone or in combination, and currently we have over 25 different ICD-9 codes for congenital heart disease, meaning there's multiple types of defects. The recurrence risk is about 2 to 3%, but that may vary depending on the type of defect the person has, whether they're a little bit higher than normal. But I get this asked all the time, what is my chances of having another child with congenital heart disease? And I've seen the gamut of, this is a couple's first child who has congenital heart disease, subsequent pregnancies are fine. Or I've seen a mother present that her sixth child that's with her has congenital heart disease, and the other ones have been fine. We often see that congenital heart disease can skip a generation. So oftentimes when I'm acquiring about their family history, I ask if their grandparents have had any sort of a heart murmur diagnosed young, or any children in the family that died suddenly after birth. More than likely, that's congenital heart disease related. If you just ask in general about heart disease, they'll tell you about their grandfather who had an MI, and that's not congenital heart disease. So mostly anybody diagnosed with a murmur at a young age, or required heart surgery at a young age, or any siblings that passed away shortly after birth. Congenital heart disease is not just for children anymore. And presently we have 2.4 million people with congenital heart disease in the United States. And it's 1.4 million adults and 1 million children. I've been giving lectures on congenital heart disease for probably the past 20 years of my career as a nurse practitioner in this area. And for the first time, I'm stating that we have more adults than children with this defect. And it's a true testament to our advances in medical technology, our postoperative management, and more so to say our early detection, which I'll be talking to you a little bit about. Currently, we have 300,000 have what we call complex congenital heart disease. And there's various groups of mild, moderate, and severe or complex. And it's the ones that have complex congenital heart disease that we will be talking about a little bit later that need antibiotic prophylaxis prior to dental procedures. The adult CHD population is estimated to grow at a rate of 5% per year, and it is now a chronic disease that adult cardiologists are receiving subspecialty training in. And why am I showing you a picture on the right-hand side of the screen here of our pediatric nurse practitioner graduation class of 2017? It's because the girl that's highlighted there in yellow was one of my former students here at the School of Nursing, and she has complex congenital heart disease, and she was born with a single ventricle where most of us have two. These children about, I'd say, 3 or 4 decades ago did not survive, and now they are surviving and they are thriving. And she's actually in a primary care provider now in Portland, Oregon. And it's just a true testament to what we've done and what we've accomplished over the years in regards to children with complex congenital heart disease and surviving. So coming to a pediatric and family medicine or dental clinic near you, you will definitely see patients with congenital heart disease. And this is separate from what you're going to see potentially in adult patients. The etiology for congenital heart disease, you can see that Y with the question mark up in the right-hand corner. If I had $1 for every time I had to talk to a parent with a new diagnosis for congenital heart disease, and they said, why me? Why did this happen to me? I would be rich at this point. Oftentimes the mothers will sit there and remember everything that happened during their pregnancy. And I was exposed to some paint fumes when we were remodeling our house, or I get a lot of different questions. And unfortunately, we oftentimes don't have a good answer. Sometimes we do, and more so now we may have, but usually it's a non-specific cause. It's multifactorial in about 85%. That can be either a genetic predisposition where we see it passed down in families. It can also be an environmental teratogen. And if any of you live or know of the Bakersfield area, oftentimes we see a lot of children come from that area with congenital heart disease, and that's a farming community, which many of you know, and there's a lot of pesticides and things like that done. And it would be a wonderful epidemiology study to perform at some point, but just in my own clinical experience, we see a lot come from the Central Valley areas, or it can be just a random event. And I used to get really mad at a physician that I worked with who used to answer these questions to parents. Oh, it's just bad luck. But it's more so this is an unexplained random event. And then if we look at further down, 10 to 12% have a chromosomal or a genetic abnormality. Most commonly we see in the trisomies, 13, 18, 21, and 50% of children with trisomy 21 will have some form of congenital heart disease. So we automatically ultrasound them regardless of whether we hear a murmur or not on them. DeGeorge syndrome, Noonan syndrome, Marfan's, Turner's, Williams, there's a host of genetic conditions that the heart may be associated with them. We know in utero that the brain and the heart develop simultaneously. So if there's a defect in one area, most likely there'll be a defect in another area. And oftentimes it's midline defects that occur, such as the brain, the heart, the intestines, the kidneys. So midline in the body, a lot of the times we see things connecting. And then the corresponding defect is listed on the opposite side there. PS meaning pulmonary stenosis, ASD is an atrial septal defect, aortic regurg, mitral regurg, coarctation of the aorta, aortic stenosis are just what those abbreviations are. And then about only 2 to 5% are really what we consider maternal factors. And those can be infections that may occur during pregnancy, medications that the mother may be on. Most likely we see congenital heart disease in mothers that have seizure disorders that are on anti-epileptic medications such as Dilantin and valproic acid. Also, probably even higher than that, we see in the autoimmune diseases such as lupus, as well as diabetes mellitus, and that is probably the #1 maternal condition that we see congenital heart disease in. And this isn't gestational diabetes that you get during pregnancy. This is type 1 insulin dependent diabetes, and we don't know why. We don't know what it is with potentially the insulin replacement that causes this, but it's something that we see pretty significantly. Prenatal and postnatal screening, there's no real primary prevention for congenital heart disease. We do have increased prenatal detection. Typically, a fetal ultrasound is done in every mother between 16 and 24 weeks by their obstetrician. And if they are unable to see the main structures of the heart, and typically in the fetus, we want to see that there's 4 chambers, that the aorta is coming off of the left ventricle, the pulmonary artery is coming off the right ventricle. Sometimes we can't see little nuances such as holes in the atrial or ventricular septum, but we can see major structural related issues. If it is suspected, the obstetrician will refer that mother to a pediatric cardiologist that specializes in fetal echocardiography. And your big kind of centers for referral, if you're going to be practicing dentistry in Southern California, is Children's Hospital Los Angeles. There's a fetal clinic, as well as UCLA and CHOC. All of the major children's hospitals will be able to perform fetal echocardiography. And this allows for a controlled, planned delivery if it's noted. And though it's often a shock for families, they then know about it, they can cope with it in preparation, and then educate themselves a little bit about the disease and the process and what will be required. But most importantly, that time of diagnosing it prenatal gives them time to grieve the loss of what they had anticipated on as a healthy child. We see a lot more difficulties when it's diagnosed after birth, and the parents are in shock, and we have to respond urgently, either with surgery or medical treatment. And it's often very, very overwhelming, if you can imagine, to the families. So prenatal diagnosis is typically the preferred method, and it's becoming the most common method. Anywhere, any reference that you look at will say anywhere from 50 to 80% of congenital heart disease is diagnosed prenatally. Early postnatal detection is probably the second most important thing that has improved survival and emergency room visits with newborn babies in extremis from undiagnosed congenital heart disease, is the law that was passed in California in 2012, as well as this is nationally. It's not in law in certain states, but it is mandated, or guidelines are provided that it should be done. But the CDC recently added to its newborn screening the critical CHD screening test that must be done in all babies born that are in the well baby nursery prior to going home, typically within 24 or 48 hours after birth. Nurses are required to perform the critical CHD screening, which is obtaining an oxygen saturation level in 2 extremities and assessing its value. And there's a nice algorithm that they use to determine whether the child needs further evaluation or can go home. And typically what the screen does, it picks up the 7 top critical congenital heart defects that have cyanosis associated with them. And just so you know, cyanosis is not visible until your oxygen saturation level is less than 85%. And so this screen is able to pick up children that may have an oxygen level of 89, 88% before it drops and gets lower after their fetal communications start to close after birth and their fetal circulation has transitioned over. So this is very key, and it's also after doing this now for probably getting close to a decade, the screen, we're finding that it's also picking up respiratory conditions or malformations that cause low oxygen saturations. So it's not just cardiac, it's actually benefiting children with pulmonary disease as well. This is just a picture that I like to show everybody because this is cyanosis that you will never see in the United States because we will intervene before a child looks this bad. So these are twins, and I saw these children when I was on a medical mission in Russia. And you will notice that if you look at the boy, he's a little bit larger and bigger than his sister. And that's typically what we see in kids with cyanotic heart disease. They're often shorter and they often don't gain weight. So they plateau on their height and their growth curves when they get assessed in their by their pediatric provider. You'll also notice that if you look closely at her for being so cyanotic, if you're a pediatric provider listening to this, and you would see this kid come into your urgent care or emergency room, the first thing you would do is put oxygen on her. You'd be, oh my God, look at this kid. She's really cyanotic. But notice that she is not in respiratory distress. You would think somebody that cyanotic would be struggling to breathe and tugging and subcostal retractions and gasping, but she's not. And that in and of itself, cyanosis in the presence without respiratory distress is cardiac until proven otherwise. And this is related to a structural problem or an obstruction in the heart and not a resistance problem like you would see in somebody that has pneumonia, bad pneumonia. They're a little cyanotic and dusky around their mucosal membranes, but you put oxygen on them, it's a vasodilator, it will relax their pulmonary bed and their oxygen saturations will come up. This is different. I could give her 100% oxygen via a face mask and it won't make a difference in the world because it's an obstruction to flow. And then here's her picture afterwards in Russia when we did her tetralogy of flow repair and we relieved the obstruction underneath her pulmonary valve. She immediately pinked up after surgery. So this is completely reversible. And again, I just wanted to show you the picture of cyanosis, and we're going to talk about how that can affect the teeth in these children. So why congenital heart disease is prone to dental disease? More so in particular cyanotic heart disease because of the poor oxygenation that is systemically in the body. That systemic blood flow is the blood supply that's going to the teeth as well too. So this interferes with the development of the teeth as well as the tooth enamel in the primary dentition. because the enamel surface is rough, it's pitted, and can be concaved in areas. The tooth can be hypoplastic in nature. There's an increased susceptibility for dental caries on these teeth. These children often have feeding problems and feeding difficulties, and that's because of their cardiac output. They are circulating mixed blood throughout their body, and they're not being able to utilize the calories that they need to grow and gain weight with. They're burning it off. Their metabolic requirements are too high. So they have to eat a lot, and often these children eat very slowly. A normal baby could take a few ounces via a bottle in 15 minutes, maybe 20 minutes tops. The child with complex congenital heart disease will take 40 to 50 minutes to take that same volume. There's also, oftentimes they can have reflux or regurgitation and vomit frequently, because when your cardiac output is not good going down your aorta to your mesenteric artery in your stomach, they oftentimes will vomit and have frequent emesis, more so than a normal child would. So their teeth can be exposed to stomach acids from either regurgitation or vomiting. As I mentioned before, poor weight gain, malabsorption, your cardiac output is poor going to your gut. You're not going to be able to break down your foods well and absorb the requirements that you need. So oftentimes these children are on a high calorically dense formula, where normal newborn formula is 20 calories per ounce. We often have to have these families mix it to 24, 27, or even 30 calories per ounce formula. Because they're going to take a smaller volume, it really needs to be packed with as much calories as we can. And oftentimes, instead of eating, 3 meals a day, they have to eat frequent meals, which we know is not good for the teeth at that point. So these kids often, their diet and what they're eating often affects their risk for caries, as well as the medications that they take can often be acidic. They're compounded elixirs, meaning there's no liquid form for kids, so we have to take the adult pill and break it down, make it into an elixir, and then we have to sweeten it so it's palatable for them to swallow that medication. So they take a lot of medications, particularly in that 0 to 5 years of age, which they're at highest risk for dental caries. They're on a lot of cardiac medications, as well as diuretics, which can dry the mouth and decrease their production of saliva in their mouth as well too. Often they present to the dentist late. The parents are consumed with their heart problem and getting them to their appointments. That there's been many studies that I looked at in the congenital heart disease group saying that their teeth were kind of not as high of a priority per qualitative studies, where parents were able to explain why they hadn't sought a dentist for their child to be seen, knowing that their risk is higher for infectious endocarditis. So oftentimes they don't present to the dentist until they have symptoms. They have a tooth that's bothering them, they can't chew, they can't eat. And by that time, when they come in to see the dentist, they have advanced caries disease, and their dental restoration requires a significant amount of work and also general anesthesia in the hospital setting. So if we can get to them earlier, get them in to be seen earlier, we can minimize their exposure to advanced caries, a lot of restoration being done at that point. In my clinical practice, I pre-screen kids coming in for surgery, and I can't tell you how many kids I have had to cancel because of having bad dental caries prior to going in for their cardiac surgery. So if you think about it, they've seen a pediatric healthcare provider who didn't look in their mouth that closely. They've seen a cardiologist who obviously didn't look in their mouth closely. And they've also seen a cardiac surgeon who I know doesn't look in their mouth when they come in for their consultation visit. So they've gone through 3 healthcare providers before coming to me, and I can open that kid's mouth and see extreme dental caries that I can't let them go into surgery, get prosthetic material or things put in, and then seed that with a bad caries that requires filling or something else to be done after having heart surgery. So these are the predicaments that I see pretty much on a daily basis. We're seeing kids with this. So the word that needs to get out is early prevention, getting them to see a dental provider sooner versus later, and making it a priority, just like they make their heart condition a priority. This was a great study that was done in 2018. And it was published in the Journal of Canadian Dentistry, where they looked at oral health of children with congenital heart disease in a pediatric health science center. And 50% of the kids with congenital heart disease, which was about 156 children, had severe early caries. And that was in a mean age of their sample at 43 months. And their dental treatment for 83% of them required a general anesthesia. Oftentimes, as said before and said in this article, they present way too late to be seen by a dentist. And then they have severe disease that requires extensive restoration. And this was interesting, the last bullet point here, that average treatment was 4 restorations and 2 extractions, and the cost was $2,154. And that's a significant amount of money that could be prevented. And then this table over here on your right-hand side were just the reasons that indicated treatment under general anesthesia. And oftentimes, yes, the patient is going to be not cooperative, particularly between the 0 to 5 years of age. So the age factor, in addition to extensive treatment needs and 72%. And then on top of it, there's an urgent need for cardiac surgery. So if you really think about this, by me canceling that kid that I saw dental caries on the day before they come in for their heart surgery, they're in need of that heart operation. So now we gotta wait, we gotta get them into the dentist to be seen, and then 99% of the time, they're going to need anesthesia. And anesthesia should not be taken lightly in these children with complex, and I'm saying complex, congenital heart disease that have shunts or are in between palliative heart operations, because oftentimes anesthesia will change the child's hemodynamics in their heart, causing shunting to go a different way. And oftentimes it may precipitate itself into a cardiac arrest situation. And unfortunately, I have seen children that have died undergoing dental procedures with general anesthesia. So these things should not be taken lightly. And these were in centers that had pediatric anesthesia in a hospital-based center. So if nothing else that you get from today's takeaway is the importance of making sure those high-risk children are referred to a high-risk setting where they can be taken care of. There's obviously, we all know here about the teeth-heart connection. They share the same blood supply. That's why cyanotic blood going to the teeth is not going to promote optimal growth. The same bacteria that leads to caries in the teeth can travel to the heart and cause these life-threatening infections called endocarditis. And though it's not as common, I have seen it happen, and I have seen children die from endocarditis as well. So infectious endocarditis, formerly known as subacute bacterial endocarditis, you may have heard, probably a decade ago, where's your SBE card for when you go to the dentist? They now call it IE, or infectious endocarditis. And it's an invasion of the bloodstream by microbes that colonize in the endocardial lining of the heart. And that lining of the heart, you can see on the picture on your right-hand side. The endocardium is the very inner lining of the heart. Then you have the myocardium, which is the main muscle of the heart. And this is a cross-sectional view here from the heart. And then in between there, you have the parietal and the visceral pericardium, and that space in between is called the pericardial cavity. But that's just a cross-sectional view of the heart, and knowing that it's this endocardial lining inside. There's an estimated incidence, and the references can vary on this, of 3 to 9 cases per 100,000 per year, with 50% of IE cases having known heart disease. There are other reasons that you can get infectious endocarditis, and that's in an up and coming slide. But 14 to 20% of these cases are due to oral hygiene. And we can pretty much track these things by, when they present with endocarditis, and then asking them when when was their last dental exam or procedure that they had done. There's an increased incidence here in congenital heart disease, secondary to improved survival. Oftentimes we see IE in kind of remote countries that have an increased incidence of rheumatic fever, because rheumatic fever often leads to lifelong valve disease, and this valve disease presents itself as an increased risk for endocarditis. It's often in indigenous or poor populations that lack penicillin, is primarily what we see. The other risk factors for endocarditis from congenital heart disease is anybody that has heart valve disease, previous heart valve surgery, IV drug users, previous history of endocarditis. You can get it again. indwelling central lines, chronic hemodialysis catheters. We can see this in the neonatal population in the NICU that has indwelling lines in for a while. Anything where bacteria can stick to and colonize, and it's a petri dish for growth. We see these with indwelling sorts of lines, as well as poor dentition. There's an estimated 500 oral cavity species of bacteria. In infectious endocarditis, the most common bacteria cause with or without congenital heart disease is Staph aureus. And then the second most common cause is Strep viridans. There can also be causes from fungus-related fungal infections in the bloodstream. And these are often the more severe cases that you'll see. But we can tell oftentimes by echocardiogram too, whether we have Staphylococcus versus Streptococcus, and we don't really need the blood culture to tell us that. So Staphylococcus appears in these grape-like clusters that you can see here. And then strep often appears in these chain-like clusters that you can see that will attach onto a valve or some structure, and it will just hang down, or these grape-like clusters that you can see. Oftentimes, Strep viridans is more common in the mouth. So if that comes back on our blood cultures, we can pretty much narrow that down to a potential dental cause. And Staph aureus is often skin related on the surface. IV drug abusers that are injecting heroin into their veins will go up through the venous system, and we will see more of these bacteria vegetations on their tricuspid valve and their pulmonary valve with IV drug abusers, because it will go to the right side of the heart and not the left side of the heart. This is just a little picture. This is kind of a cartoon schematic on your right hand or left hand side with these kind of grape-like clusters. So if you think about it, your valves are opening and closing here, and this vegetation can shoot up. It can go to the aorta, out the aorta, through the transverse arch, up to your head vessels, and that infectious organism can give you a brain abscess. And sometimes patients with IE will present with also neurologic conditions and a potential brain abscess. And here's actually, I think you can see my pointer here, is actually a gross cross-sectional view of a valve here. These are the chordae coming down from the valve, but look at these grape-like clusters that start destroying the patient's valves. And typically we see more so the aortic and the mitral valve with endocarditis. So infectious endocarditis, the clinical findings, oftentimes they will present, just for your own knowledge, I think it's important, a high fever of greater than 102, a previous kind of viral illness that they may have. All of a sudden they have a new heart murmur that they didn't have before, or their previous heart murmur now has a louder sound transmitted from it. They have general malaise, sweats, headaches, petechiae you can see in the distal extremities. And why is that? Down here in yellow, it's septic emboli. So what these clinical signs down here that we're going to be seeing are related to septic emboli shooting off from those valves, going out the aorta, and it will travel to the distal extremities, your fingertips, your toes. So Roth spots are present here, and this is when you're doing a fundoscopic examination. You can see these hemorrhagic spots with a central white clearing to them. Those are called Roth spots, and those are due to septic emboli. Osler's nodes, which you can see up here, which are related onto the fingertips here and toes. They're little red spots, they're tender, and how you differentiate Osler's nodes compared to Janeway lesions, which are typically on the palms of the hand and the feet, the spots. They're not at the tips. Osler nodes are raised and Janeway nodes are flattened. And then more so in adults, you will see on the nail bed these hemorrhagic splinters that you can see on the nail beds. We don't often see them in children, but if we have a patient admitted to the hospital with infectious carditis, you will see people looking at their nail beds regardless that they're not an adult. But how we diagnose it, the diagnosis is based on the clinical exam findings as well as blood cultures. And blood cultures are typically positive in greater than 90% of the cases, and it requires 3 blood cultures to be sent over a 24-hour period. And obviously, if the patient has central lines in, we're not going to draw a blood culture from that line. They should be peripherally obtained venous samples. Oftentimes we don't get 3, and 2 is probably the max that we get, but we do want to get those before we start antibiotics. We want to find the identifying organism before we start giving antibiotics to treat it. And once the cultures come back, then we can tailor the antibiotics more appropriately to the specific organism. But you'll see in our inflammatory reactants will be elevated. Our erythrocyte sedimentation rate, or ESR, our C-reactive protein, and our white blood cell count can all be elevated, and that's a non-specific finding. Anemia may be present if they've had this for a while, or other chronic illnesses. Microscopic hematuria in their urine from the septic emboli to their kidneys. An echocardiogram vegetation is a positive finding for endocarditis. No vegetation, though, does not rule out endocarditis. It may not have developed yet, but if the clinical picture and the blood cultures match, it's treated as such. And also the echo can pick up new valve regurgitation from the destruction from the bacteria. And here's a picture of an echocardiogram. The chambers are labeled. So this is the mitral valve here, and you can see these kind of clusters attached to the mitral valve. It should appear more like what you see on the opposite side. Infectious endocarditis treatments here. Long-term antibiotics are required. We oftentimes have to cover for both gram-negative and gram-positive organisms. So they'll typically be on oxacillin or vancomycin and gentamicin. And it's a 4-week treatment course. It's pretty significant. They require a peripherally inserted catheter or a PICC line, and infectious disease and cardiology will follow them in the outpatient area. But indications for surgery, we typically like to treat them with antibiotics until their blood culture is negative, and then we send them in for surgery. But oftentimes you may never have a negative blood culture despite having therapeutic antibiotic levels. So that's often an indication to go to surgery to remove that vegetation, and then you hit them pretty hard with antibiotics after. They'll also need surgery if they end up with severe valve regurgitation or dysfunction from the infection. If there's emboli or vegetation in there, we have to go in and remove it. It's a source for emboli and other significant sequelae. Arrhythmias can also occur from this infection. And so these are indications for surgery, and we remove the infected material, and we may have to repair, but more likely replace any of the affected valves. But the key, that was just a quick little overview on endocarditis, but the key is for us to prevent this from happening. And there were previous American Heart Association and American Dental Association guidelines that were published in 1997, and they were revised in 2007. We are still using these revisions with a few updates that came out in 2017. But this is the main article over here, which you can see one of the main changes was that we found that infectious endocarditis is only affecting a very small number of cases. You know, we need to consider, do we need to be giving them antibiotics before and after a dental procedure or another type of procedure in an area that is high risk for infection? So they decided just to give antibiotics before dental procedures, and we don't have to give anything afterwards for high-risk cases only. We were giving it to a lot other kids, and now we're not really needing to. The evidence was not there on the scientific statement by following these children out. Prophylaxis is reasonable for all dental procedures that require, and these are the key aspects for you: manipulation of the gingival tissue, the periapical region of the teeth, or perforation of the oral mucosa. This is where they consider in high risk only kids, and I'll specify what that is on the next slide. And you're going to be doing any of this to them, then it requires prophylaxis. And the recommendations are not solely on an increased lifetime risk, and they're not recommending anymore for GU or GI procedures such as colonoscopies and things like that. They're not requiring prophylaxis for that anymore. So who gets it? The highlighted areas that are in red here are from 2017. And so the children that get endocarditis, if they have a prosthetic cardiac valve, if they've had previous bacterial endocarditis with or without heart disease, if they have specific cardiac malformations, and these are only high-risk complex CHD. And I listed them out for you here under the first bullet point, which is unrepaired cyanotic congenital heart disease, meaning that they're using various shunts and conduits. And I have a picture to show you so you understand what that is. When somebody presents and you're going to be doing their dental procedure and they say that the mom tells you, oh, my child has tricuspid atresia and right now has a BT shunt in place and their oxygen saturation levels are 84%. You'll have a little bit of understanding of what that is. Completed repair CHD with prosthetic material or device, whether placed by surgery or catheter intervention during the first 6 months after the procedure. So anybody that has heart surgery that's repaired, they get endocarditis prophylaxis only if they have to go to the dentist within the first 6 months after their surgery. And that's to cover them until their own body endothelializes the tissue up around. And also repaired CHD with a residual defect at the site or adjacent to a prosthetic patch or device. And this is an important one to think about that people don't always, in that oftentimes our repairs that we do on these kids are not perfect, and there can be a residual patch leak that sits up around the aortic valve, and it doesn't go away, and the body doesn't endothelialize it closed with their own body tissue growing around these patches, and they have a permanent little shunt there. That kid needs antibiotics before dental procedures, as well as kids that have had cardiac transplantation, and their transplanted heart may have some valve regurgitation. We're using a lot of imperfect hearts now to give to patients that may have a little bit of leakage here or there, but functionally it works well. If that is the case, they will require prophylaxis. And here's just an example. Remember that little girl that I showed you who was cyanotic? This is the heart defect that she has. She has an abnormal stenotic pulmonary valve. There's typical muscle growth underneath that pulmonary valve, and there's a hole in their ventricular septum. So blood can travel from right to left and go out the aorta into the body. And oftentimes, if they can't have complete repair as a baby, they will have a shunt in place. So on the guidelines where it says shunts or conduits, this is an example of a synthetic Gore-Tex shunt, and it's artificial material, and bacteria can adhere to that. Blood can clot to that and cause obstruction that way. And here's another example. This is a transannular patch, but some people also refer to that as like a conduit. And this is also in the pulmonary outflow region. And then there's a patch here as well. And these children will need endocarditis prophylaxis. As we mentioned before, the trisomy 21 and the high prevalence that we see with atrioventricular canal defects, they typically have mitral valve issues, as well as various holes in the top chambers and bottom chambers of their heart that require patches to be put in place that may or may not have a residual leak associated with them. But speaking of trisomy 21, I just wanted to have a slide and bring to your attention. You will see these kids in your primary care or dental practices, and the kid with trisomy 1 with congenital heart disease is at high risk for dental caries, early dental caries, and other sorts of dental related issues. We typically see a delay in teeth and jaw development in these kids here. Oftentimes, their primary dentition may not come until around age 2 that we see. So, and their teeth, when they do come out, may be smaller than normal. Their mouth is often smaller, and their tongue may protrude a lot and have poor manual dexterity. And these two things here can often cause difficulty for them to clean their teeth, brush their teeth, floss their teeth, because their mouth is smaller, their tongue is more enlarged, filling those spaces up. So they may have a problem just in dental hygiene. There's also reduced muscle tone in the mouth. So oftentimes when they're chewing, they may have some difficulty clearing all the food in their mouth, and food can be stuck to their teeth. A certain percentage will have allantoaxillary instability, which is the increased mobility in C1 and C2. And that's something just to be aware of when you're positioning them in the dental chair, making sure their head is in a line and they're not too hyperflexed back, because they may impinge on their spinal cord and develop weakness in their arms and their lower legs. Their small nasal passage may cause mouth breathing, dry mouth, fissures of the mouth and lips, and can contribute to halitosis. And this is just an example of a patch, and there's a residual leak around that patch that goes under this aortic and pulmonary valve. And as we already talked about, valve regurgitation, valve stenosis are all prime areas for bacteria to settle on. Valve repairs versus replacements, just so you have a little visual of what that is. We have different types of valves that we use. We have mechanical valves, which are metal, and they typically have a little ring or cushion of material here, which you sew the valve in place to the appropriate location. Most of the time that's in the aortic side. Also, there are what we call bioprosthetic valves, which are part metal. There's a metal scaffold in there. And then there's tissue on it, and it can be bovine tissue from a cow, or it can be porcine tissue from a pig. It can be their valve leaflets or their pericardium that's used to make a bioprosthetic valve in. And there's typically a cusp that you use to sew it in place. The big thing is mechanical valves require blood thinning medications such as Coumadin. That's something you're going to want to know before you start digging around in their teeth or doing a root canal or an extraction, that kid's going to bleed a lot who has the mechanical valve in place. The bioprosthetic valves, typically they're on a little bit of Coumadin for a few months, but then they're on aspirin afterwards, and that should be fine for what dental procedures they will be getting. Interestingly, on the updates that were provided to the guidelines, they added annuloplasty rings, and I wanted to show you that so you're aware of it. They added annuloplasty rings and percutaneous valves. And so somebody that has a leaky valve, because the annulus that the valve sits in is dilated, but the leaflets themselves look great. They function, they move up and down, but the annulus that the leaflet sits in are dilated. And we see that in cardiomyopathies and other sorts of heart disease. You can take this little rim, and it's metal inside, covered in a Dacron synthetic material, so that you can sew in it, and you can actually cinch that valve down and make it small, so it's not so dilated and enlarged, and then the valve can work properly. So this annuloplasty ring, if somebody tells you that they've had a valve repair and there's an annuloplasty ring card that they have, that requires prophylaxis, as well as these are new. This is the hot thing out there. They're being put into kids and adults because it does not require open heart surgery. You don't have to do a sternotomy, open their chest to replace a valve. These are what we call percutaneous valves that are placed in the cath lab, and they're placed via the groin through, depending if you're putting a valve on the right side, you're going to go through the femoral vein. If you're putting a valve in on the left side, you're going to go through the femoral artery, but you can see these valves get pulled up here. A balloon dilates their native valve that's in there, and then it will open up and deposit a new mechanical valve in place, or it's not mechanical, it's a prosthetic, a bioprosthetic valve. It's a tissue valve in a metal scaffold here, which you can see. These valves are showing more and more problems with endocarditis. And here's an extracted one of these transcatheter valves put in. I've said pulmonary in the title on this slide because in kids, we most commonly put pulmonary valves in. In adults, you would see aortic valves like this put in. So, but for kids, more so, we will only do pulmonary valves at this time. This is a slide just with other procedures that need prophylaxis, not just dental, for respiratory tract, tonsils, and adenoid removal, any sort of respiratory tract drainage or abscess or skin abscess requires prophylaxis. And if you're not sure and the patient has a cardiologist, please call them and they can let you know whether that child needs that or not. I'm not going to read these next two slides to you. It's listed here for you, for the dentists in the audience. These are the dental procedures that you're doing that would need prophylaxis on an eligible kid with cardiovascular disease. And those things are all listed here, but the primary thing is in red here per the guidelines. If you're going to be manipulating these areas or structures, it requires prophylaxis. These don't, and I think some of these things are pretty intuitive that were listed as well, taking radiographs, fluoride treatment, you know, those sorts of things I think are in shedding of their primary teeth. You don't need those sorts of things. These are the guidelines for antibiotics. Standard regime is amoxicillin, 50 milligrams per kilo. If you're giving it orally to the child, it has to be given 1 hour before the procedure. If the child is in the hospital and you're doing their dental work under general anesthesia, they get it IV and it's 30 minutes before the procedure. It's still the same dose. The maximum is 2 grams. And depending on the route is when you would give the instructions on when to get it. If they are penicillin allergic, you can use clindamycin, and that amount is given. Plus there's other medications listed here that you can look up on your own. And is IE prophylaxis indicated in congenital heart disease in these sorts of cases? There is nothing written in the guidelines as to what we do in this case. We obviously don't encourage it, but as you know, kids are going to do what kids want to do. And if they really want to do it, I tell them to do their homework, make sure they go to a reputable place that has a good sterilization procedure and skin prep associated with it. And I would prophylax them before going to do this, because as you can see in the mouth, there's your strep viridans, and here is your Staph aureus on the picture on the right. And if you Google infectious endocarditis in PubMed, there is 1 million case studies of IE related to tongue piercings, tattoos, things like that in people that do not have heart disease. So these things should not be taken lightly. On the American Heart Association website that's listed below here is the AHA and the American Dental Association endocarditis wallet card that should be given to families by their cardiologists. And I say should, it doesn't always get done, but we try to make sure it does. They get a card and their diagnosis is on it, who their doctors are, the date, and it goes over everything. It has the antibiotics needed as well too. And this was just recently updated in 2020, and you can go in and print them off and fold them up and use them if you like. There's also a card in Spanish as well too. So if you forget what the antibiotics are, you can just pull them up on the card and they will show up on there. Best practices. This was an article that came out in 2017 in the Journal of the American College of Cardiology, which really just updated what we're doing and the central themes of infectious endocarditis, looking at prevention strategies, diagnosis, and management. And you can really see highlighted is the good oral hygiene for at-risk groups, as well as antibiotics. And prevention is really better than trying to cure them of this. So this is another, just some handouts, some educational information that's out there from the American Heart Association on for congenital heart disease patients, on infectious endocarditis. And this is the Public Health Consortium for Congenital Heart Disease that I'm involved in. And they put out a handout for parents in regards to early dental care and what things are required for them to follow up with, and the importance of preventing endocarditis. And here's the guideline references are listed here. And if you have any questions or after reviewing this, please feel free to email me on the email above. Thank you very much for your attention, and look forward to working with you, or maybe even seeing you in interdisciplinary practice in the future. Thank you.